adjuvant trials in advanced renal cell carcinoma. Contemporary cancer-specific survival is like this. As you already know, cancer-specific survival, SIJ score 5 by 6 is about 50%. It means 30% patient will have a tumor recurrence within 5 years. For high-risk patient, this increase up to 60%. This means adjuvant therapy is needed to prevent recurrence. This slide is very busy, but it's not important because adjuvant trial using immunotherapy is not successful. We already successfully treat metastatic renal carcinoma with VEGF agent. So, 3 adjuvant trials have reported result: ASSURE, ASTRACT, and PROTECT. So, let's move on to 3 adjuvant trials. When considering adjuvant trial, correct patient selection is very important. Many nomographs developed to predict the recurrence, such as conventional TNM stage, UISS, SIG score, etc. UIS score based on TNM stage, common grade, issued performance status is categorized into low, intermediate, high risk group. Can you move on to the previous slide? Anyway, UISS score categorizing renal cell carcinoma previous where predict the recurrence rate. Anyway, sorry. PROTECT trial is evaluate the effect of pazopanib after nephrectomy in patients with localized advanced renal cell carcinoma. A total of 1,500 patients with intermediate high renal cell carcinoma randomized into pazopanib or placebo to this for 1 year. The primary endpoint of disease-free survival shows no difference between any treatment group. ASSURE trial is to evaluate the efficacy of adjuvant sorafenib or sunitinib for unfavorable renal cell carcinoma. A total of 20,000 patients with intermediate high-risk group randomized 1:1:1 ratio to receive sunitinib, sorafenib for 1 year. Primary endpoint of disease-free survival result is shown here. There is no difference between any treatment group. Overall survival also did not differ between any treatment group. ASTRACT trial is a randomized, double-blind, phase 3 study of adjuvant sunitinib in patients with high-risk recurrent renal cell carcinoma. A total of 600 patients with intermediate high-risk group was randomized to 1:1 ratio to receive sunitinib for 1 year. primary endpoint of disease-free survival shown here. The difference between the curves are significant. The median duration of disease-free survival was 6.8 years in the sunitinib group and 5.6 years in the placebo group. Updated result of abstract trial was published last year. The result confirmed the adjuvant sunitinib therapy over placebo. Secondary endpoint of overall survival is shown here. The hazard rate 0.92, which means insignificant. Disease-free survival subgroup analysis shows subgroups favoring sunitinib is age less than 45, normal weight, ECG performance stage 0, and Perlman grade 3 or 4. Adverse events already you know, the diarrhea, hand-foot syndrome, etc. So, this, as I already said, in Asia trial, adjuvant, the result of Asia trial did not show the benefit of adjuvant sunitinib trial, sunitinib therapy. By contrast, the benefit of sunitinib therapy is proved in abstract trial. So, what's the difference between abstract and Asia trial? Major differences are risk stratification and dose administered. In Asia trial, setting dose level is maybe possible to lower, and minimum dose reduction is allowed. So, appropriate sunitinib dose was not reached in Asia trial. Looking at the risk stratification, in abstract trial, patient had nodal disease or minimum T3 stages, meaning high risk renal cell carcinoma. In Asia trial, the eligibility criteria of Asia trial is had intermediate and high risk renal cell carcinoma, which means the enrollment criteria of Asia trial is broader than that of abstract trial. So, abstract and Asia trial are not comparable, and exposure to the drug is important. Patient selection is likely to be crucial. Patients with high-risk tumors are more likely to benefit from adjuvant treatment. Median disease-free survival with sunitinib treatment was longer than that with placebo. In the high-risk group, median disease-free survival improved by 2.2 years versus placebo. Median overall survival now reached for either treatment arm. Summarizing sunitinib as an adjuvant treatment. High-risk patients have a 6% risk of recurrence following nephrectomy. So, we may need adjuvant therapy for high-risk patients. Disease-free survival prolonged by 2.2 years in a higher risk group. So, sunitinib is favorable for patients with high risk of recurrence. So, are we ready for adjuvant sunitinib in high risk renal cell carcinoma? Summarizing 3 trials: Asia trial, no difference in disease-free survival and overall survival. PROTECT trial, no difference in disease-free survival. Abstract trial, improvement in disease-free survival, not overall survival in high-risk renal cell carcinoma. Canada consensus statement summarized like this. Adjuvant TK-based adjuvant therapy is not recommended for routine use. However, highly motivated patients may benefit from a discussion with their oncologist regarding the risk and benefit of adjuvant TKI. EA guideline concludes, recommend do not offer adjuvant therapy with sorafenib or pazopanib. Strength rating is strong. Do not offer adjuvant sunitinib following surgically resected high-risk renal cell carcinoma. Strength rating is weak. This is very similar to Canada consensus statement. NCCN guidelines recommend adjuvant therapy after radical nephrectomy in patients with stage 2 to 3. Recommended category is 2B, which means level of evidence is very low. However, intervention is appropriate. Thank you for your attention.
I'm sorry for